Hello everyone, how's it going? And Brittany has joined, so it's gonna be a fun day today because we have a special guest and I will invite her to this meeting.
Hey,
How's it going?
good. How are you?
Oh, not too bad. Good to meet virtually.
Yeah, you too. Can you hear me okay?
Yeah, it's perfect.
Yeah, okay,
I
good.
think it's perfect. I guess because I know our angles are a little bit different. Are you able to just rotate the phone to the other way? Is that doable?
Yeah,
Okay, there we go.
fine. Let me just I do it this way.
Just because when I record this, I want to make sure I get it all right.
Mm,
No big deal
yeah.
if it doesn't work, but
No, that's fine. I'm just seeing what I might have to hold this way. I'm just seeing what angle worked better for me. I can make it work. Yeah,
okay. Thank you
good.
for making it work.
No problem.
Yeah, thank you again for coming on. This like live series is working out great, better than I expected. So
Yeah, it's cool that you did that. Like, it's a cool idea to do too. Very
yeah,
helpful.
like
Everyone's stuck inside right now anyway.
I was like, well, I don't have a partner or children, so I have all the time in the world. So
Yeah, very true.
I was like, well, like this is a good way to keep people engaged, and then I put it all in a Google Drive. That way, I can just pass it on to whoever,
Yeah.
and then
Yeah.
they can just kind of benefit off of it. And then in the future, we could just throw it all on YouTube, and then have like videos that we could just tell patients, hey, refer to video 13 or something like that. So
Yeah. No,
yeah,
it's a great idea. It's awesome.
and some questions for you, because you went to U of T, right, for physio?
Yeah. So I did my undergrad at University of Ottawa, and then I did my master's at University of Toronto.
Okay, cool. And what year did you graduate?
2018. So
Yeah.
coming up on 2 years. Yeah.
Okay, that's awesome. And I assume
Yeah.
because you're at Pivot Sport as well, right? With
Yeah.
yeah. Okay, cool.
Yeah. I'm there full time, and then I just do some in-home on the side.
Okay, nice. Yeah, I know a colleague of mine does that as well. Like, and quite like again, a very important topic, but like I've seen such a big, I guess, explosion of it. Like whenever I go to medical offices, they're like, "Oh, do you guys do women's health or pelvic floor?" I'm like, "No, I really wish we did, but we don't right now." And they're just okay.
Yeah.
So,
Yeah. Definitely look into it or have someone good to refer to in the area or something. I'm
yeah,
sure there's lots too in the area.
yeah, I know
Um,
physios that we've added to the team. Uh, she's interested in doing the course, so
oh,
um,
perfect.
I hope that that works out and everything. So I think
Yeah.
it's a huge thing because we could offer it here and then do the home stuff as well, and like group classes, even like have like this space I'm sitting in right now, the rack and the half rack. Um, and that's not meant to, like, a lot of people look at it and be like, oh, you're doing like Olympic lifting. I'm like, no, we're just like, we don't have enough weight here, for example, for me to squat. It's
Yeah.
just more of the movement patterns and stuff. So leasing here is a bit cheaper than Toronto, so you can get more square footage. So the idea of the gym was to like get group classes going eventually and stuff. So um, yeah, I think it's pretty good.
Yeah. No, that's a great idea. That's awesome.
Yeah, I guess it's like some people have called it like a higher end clinic, but I don't think it's like high end in that context. But it's functional, so it's nice. Is
Yeah.
your clinic, like, how is your clinic set up? How many beds and stuff do you guys have? And
We have a split between private and like out in the open. So open beds, we have 7. Yeah. And then
okay.
we have 7 private rooms.
Oh wow, that's a pretty big clinic then.
Yeah, well, we have like sport medicine doctor, like we have more than just physio.
Yeah.
So we have sport medicine physicians and then we have like massage therapists,
Yeah.
chiropractors, osteopathy, kind of, your
Okay.
range of medical professionals.
That's really
Yeah,
cool.
so
Yeah, I was talking to Yehia about that a little bit. So I was like, that's cool. That's something like I wanted to do more interprofessional work. So like we have the 2 private offices to hopefully have like an orthopedic surgeon in house.
that'd be
Um,
cool. Be
that would
really
be
cool.
cool. So I know I do some work with like the U of A rehab bed, or not the rehab bed. I do work with them, but the
Yeah.
resident program. So we shadow residents and stuff like that. So yeah, that's my dream, which might have to take a little bit of a hold now, like a little bit of a delay with.
Yeah, I know.
Yeah, it's crazy. Like I guess Toronto's, I mean, obviously a lot bigger, so I assume you see like a lot less traffic, and if you have to go anywhere, I assume, yeah.
Yeah. Oh yeah, it definitely looks different outside. Not used to
Yeah,
being so dead.
yeah, it's nuts.
Not at all.
Nuts.
Yeah.
You can still drive to work, or coming here at least.
Yeah, I
um,
know. The just missing going for like simple runs with friends, eh? It's like
yeah.
it's crazy how different everything is, but hopefully soon. Cross our
Hopefully,
fingers
yeah.
this all works out.
I think they'll like slowly be lifted and stuff like that. So
Yeah.
yeah,
Yeah.
but we're getting through it. We're doing good. So
Yeah,
thanks
we're getting
again.
there.
And this
Slowly
is
and
all
surely.
motivated other professionals too to like reach out. So I do have a friend of mine who's works as a personal trainer. So she wants to kind of expand on the topic next week, and maybe do like return to gym workouts for
Perfect.
yeah. So I can let you
Yeah.
know if that does happen, and when that does
Yeah, for
happen. So we
sure.
can, and if she joins in, she can request to maybe be on this, and like maybe like a good lead in for next week's topic, or
Yeah, what she's going to present on and stuff.
we can do whatever we want.
Yeah,
So
that's awesome.
what I'll do is I'll flip the screen over, and then you can introduce yourself again to everybody who's just joining in, and then yeah, I'll flip the screen over, and while you introduce yourself, and
Got it there. Okay.
yeah, I just got
Oh,
it.
for the thing. Thank you.
I'm
Yeah, so hi everyone. I'm a physiotherapist working in Toronto, Ontario. Sorry, my screen I'm trying to figure out. I'm used to it being this way. And I'm working in Toronto, Ontario. So I work in orthopedics in a sport clinic. And then I also do pelvic health. Pelvic health is definitely my passion. So I'm going to do a presentation for everyone just on what pelvic health is, some of the conditions you can see. I don't know who's joining in, if it's mostly other health professionals, students, or if it's people not in the field, but interested. Regardless, if you have any questions, feel free to obviously put them in the comments at any time. Perfect. That looks like a good little view there.
yeah, I can zoom it in if we need to and stuff. So
Yeah, that looks pretty good. I think that should capture the majority of it.
I'm just trying to
Okay.
like set it up on the tripod so I don't have to hold the phone the whole time. But
Yeah, you're gonna have no arm.
we'll see if this works. I'll go to the next, and you just let me know when you want to switch slides and stuff. So
Okay. Sounds good. Perfect. Okay, you good to start?
yeah,
Okay, so we're going to start with just like a few interesting facts. So one of the first ones that's really I find interesting is that in France, all women are given access to pelvic floor physio postpartum. So that is something that I really hope Canada does at one time. This is huge, and so it kind of takes out the stigma for some people of going and actually asking for it, but it also helps the healthcare professionals and the healthcare as a whole, because it takes people out of going to the hospitals, and it brings them to physiotherapy where we can manage it a little bit more conservatively. And then if you want to go to the next slide there.
yep,
So this is interesting. So 1 in 3 females experience urinary incontinence. This is a little bit more common in females than males. We will kind of get into a little bit of the differences and some of the things that you may see. But it helps to know that people aren't alone. I have a lot of people coming to the clinic and are quite timid and think they may be, the only one. But in reality, if you have a group of friends, most likely 1 or 2 of them are also experiencing the same thing. And let's go to the third one here. There we go. And so 3 months of pelvic floor physio is mandatory for bladder leakage in Britain prior to be considered for surgery, which is massive because for some of these people going in and getting these surgeries done, so it might be like a lift, it could be a mesh. Some of these can actually be avoided if we go through pelvic floor physio and go through like more of a conservative treatment. We'll get a little bit later in terms of the evidence for pelvic floor physio, but it's actually really good. So this is extremely exciting. So let's go to the next slide here. Good. So this is just kind of an overview of what the pelvic floor actually looks like. Yeah, perfect. So you can just kind of see the red on the bottom, that's the actual pelvic floor, whereas then we have the bladder, the little yellow part, the bowel, and then we just have the spine to kind of orient, and the pubic bone in the front. And it is interesting. I mean, just even looking there, you can kind of see the urethra on the left for the man. And so for women, the urethra is roughly about 6 centimeters. For men, it's around 20. So it's a lot longer. Good. And let's go to the next slide there. Good. So this kind of gets into what is a pelvic floor. And we kind of get this question all the time. Usually when people come in, they're always like, think it's kind of a black hole in there. We have an organ, we pee from it, and other than that, not much is going on. But in reality, it's a huge bucket of muscles. And so there's 5 main functions for the pelvic floor. So support or movement is kind of one. So it helps us when we're running, when we're doing box jumps, when we're walking, whatever we're doing in a day. And then sphincteric, so obviously helping us with continence, making sure that we can hold in our pee if we need to run to the bathroom really quick. Sexual, so without your pelvic floor, you can actually not have an orgasm and you can not have an erection. And then stability, so keeping in your organ support, so making sure we don't have prolapses, which we'll talk about a little bit later. And then sump pump, so this is more circulatory, so making sure that it helps kind of all the circulation come from our limbs and go up towards our abdominals and into our trunk. And we'll go to the next slide there. Perfect. So this is just a really brief overview of the layers of the pelvic floor. I know some people reached out and said they wanted to go through some anatomy, so I've taken a couple slides later to go through specific muscles. But this is the first layer, and so it's kind of that main triangle. I can't really point here, but yeah, perfect. So I don't know if you can really see that there, but right over top you can see kind of like the anal opening. If you go right above it, there's almost like a triangle formed with those muscles. And then in men and women, we both have the bulbospongiosus muscle, but in men, the only difference is that it's closed, and in women, it's open, which creates the opening for the vagina. So you can kind of scooch down to the next slide there.
Yeah.
Perfect. And so this gets to that first main muscle here. So it's called bulbocavernosus or bulbospongiosus, kind of depending on where you look. But it's that main one highlighted in orange, and it's the one that's in the center. So it kind of has the opening for females and it's closed for the males. So originating from the perineal body, which is just at the bottom, and then it's going right up to the posterior aspect of the clitoris for women, and then encircles the bulb and the corpus spongiosum of the penis for men. And so this is really helping that urethra to actually empty. It's assisting in erection for both men and women. We're talking about clitoral erection. And then compression of the tissue, so acting as like a little bit of a sphincter. So this is actually quite an important muscle. And then I'll just hover down to the one below that, the next slide.
Yeah. Let me just hit that.
Good. And this is the ischiocavernosus muscle. So this is the ones that are on the side of that triangle. So kind of coming down like, yeah, exactly, just like that. And this one's originating from the ischial tuberosity, and then it's going down to the ischiopubic bone. And inserting onto the fascia of the clitoris, or like almost underneath the penis in men. So this one helps with erection of the clitoris for women, and then it compresses the crura, or some of the penile rigidity in men. Good, so it kind of helps to maintain erection. Yeah, exactly.
I'll be
Perfect.
the pointer.
Yeah, thank you.
I'll be the pointer.
Awesome. And then we're just going to, this is the second layer. This one is obviously a little bit harder for us to kind of even assess or look at. But this one is getting into the sphincters, so things that we can't see. Unless you're a surgeon, you're probably never going to see these. But just to know that it's actually there. And then if you want to go down to the third layer, so this is more of the one that we kind of start to feel when we do an internal exam. So these ones are looking at 4 of the main muscles. I'm sure everyone's quite familiar with the piriformis if you're from a healthcare profession or a physio. But the other one, levator ani, the ischio-coccygeus, and the obturator internus, are ones that we typically don't see when we're doing orthopedic or musculoskeletal physio. I guess more of an external assessment. So it kind of shows you that little picture on the right there. It kind of gives you an overview of what those muscles look like. However, I'm going to outline the main 3, levator ani, ischio-coccygeus, and obturator internus on the next ones, just because I feel that most people are probably comfortable with the piriformis. So let's scooch down. Perfect. So levator ani, so this one is, as you can see right there, so it's attaching to that surface of the pubic bone and then going right into the coccyx. Mainly it's stabilizing and supporting both your abdominal and pelvic organs. So these are your this actually consists of 3 different muscles. So I just have at the top there the pubococcygeus, puborectalis, and iliococcygeus. We just refer to it big as like a levator ani, but this one's really important for stabilization and holding in some of those organs we have, so assisting with kind of preventing prolapse. Let's go down to the ischio-coccygeus. Perfect. So this one's a little bit further back. This one's looking into the ischial spine and coming out to the sacrum and the coccyx. This one actually helps to flex the coccyx a little bit. And then it assists in stabilizing your SI joint. So for anyone with SI joint pain, we typically see it with pregnancy or in runners or in many of our orthopedic population. Really interesting to kind of note. And then also just helps to support some of the pelvic viscera. And then we'll go to the next one there. Perfect. An obturator internus. This one's really important for pelvic and kind of your cross-link with orthopedic. So this one actually connects into the labrum of the hip. So we'll get into the hip a little bit later, but this one is attaching from the internal aspect of your obturator internus, which you can kind of see. This is a posterior view of the actual body, but you can kind of see where it attaches. And it goes into the medial surface of the greater trochanter, and one of its slips actually goes right into the actual labra of the hip. So when people come in with like hip pain or any type of like chronic hip pain that isn't going away, this is always something to kind of note because there is a pelvic floor connection directly to the actual hip joint itself. And so this one is a lateral hip rotator, and then when the hip is flexed, it assists with your hip abduction. So that's kind of an overview of the anatomy of that. If you want to go down, we just have a few kind of overlooking at the bones. It kind of just, again, orients you to where the pelvic floor. So it would kind of sit, I always say it kind of sits like a bowl on the bottom. And then if you want to go down one more. Perfect. So there's that kind of bowl situation. So this one is obviously, yeah, this one's a female one here. But if you come down a little bit further, we're going to show the difference between the female and the male. Perfect. So this one here, so the female one is on the left. So this one has a little bit more of a circular opening, so it's a little bit wider, whereas the one on the right is for males. Yeah, exactly. And so it's a little bit more narrow here, a little bit heart-shaped, which is interesting. So really important to note when you're doing a pelvic exam is that men, because they have a little bit more of a narrow pelvis, typically it is a little bit tighter than you would have a female pelvic floor. So sometimes we'll kind of say that, oh, this pelvic floor feels really tight, but it might just naturally be like that because it's a little bit more narrow and smaller. And then let's go to the, perfect. We're getting up into the fun stuff, all the conditions and everything. So this is mobility versus stability. So this is kind of an interesting little boat diagram. If you imagine that your pelvic floor is that water level, and then the pelvic organ, so thinking bladder, bowel, uterus, is the boat kind of sitting right on top of the water, and then your ligaments are like the little cords, the suspenders at the side. So if you can imagine the water level, which would be technically your pelvic floor, if it gets weak or if it has any dysfunction, that's going to lower. And now look at to the picture on the right side of that, and so you're putting more strain onto those ligaments. And so this is when you get this excessive mobility, which leads to the prolapse and potentially some stress incontinence. But on the flip side of that, if you have too much stability and that boat is, sitting right up top and that water level is really high, you're actually going to lead to a little bit more pain. And so you can actually have, some people usually think of a weak pelvic floor, but it can actually be an overactive or almost what you call too tight or hypertonic pelvic floor. So let's get into what pelvic floor dysfunction really is. So I'm not going to read out that whole thing. We're going to go through what dysfunction really means. But the big thing to note is that when you have like an impaired muscle contraction or relaxation, or something is just not effectively working, that's when you get those functions that you can result in the incontinence, the pelvic organ prolapse, pain, and some of the conditions that we're going to go through. So let's kind of scooch down here to some signs and symptoms of dysfunction. Okay, so there's quite a few that you can kind of have here. So important to note, especially if you're a student right now or if you are working in the field, things that you can kind of take note for some of the patients that might be coming in. So bowel function, you could have bloating, constipation, you could have difficulty evacuating your stool, you could be straining with your stool, you could have an incomplete evacuation. So you go to the bathroom and then you feel like you stand up and you're like, I just went, but I feel like I need to go again. These are all things to look for. Urinary function, so frequency, like running to the bathroom too often, hesitancy, urgency, like you can't make it to the bathroom before you end up voiding. Bladder pain, you might get incontinence when you're running or jumping or sneezing, you might pee yourself a little bit, which would be the stress incontinence. Sexual function, so pain for sure with intercourse or pelvic ache after intercourse. Intercourse should not be painful for really anyone. But also there's some things specific to men, so premature ejaculation and then having an unsatisfactory erection or ejaculation. And there's also something called hard flaccid syndrome in men. So this is just kind of something that to kind of look out for, something that you might feel a little bit uncomfortable with. It's probably something that your local pelvic floor physio would be more than happy to kind of discuss. And then pain, obviously any like low back pain radiating into that area. It could be pelvic pain, but completely unrelated to the intercourse. And then it could be, we can also see some chronic hip pain or pain into the abdominal walls. So let's go into the first kind of, I don't want to say condition, but pregnancy and postpartum. So this is something that obviously when people usually think of pelvic floor physio, they often think of pregnancy and postpartum. And so I get a lot of people that come in for an assessment, and they always think that it's just for women and it's just for pregnancy, which it is a big chunk of that for sure. There's a lot that we can do, but it's also just as 50% of that is also for men. With pregnancy and postpartum, I mean, you have to consider there's so many hormonal changes going on during pregnancy and its effect that it's going to have on the pelvic floor. A lot of people are quite familiar, especially if you've had babies before, with the relaxin hormone. So it's really relaxing these ligaments in the pelvis. And so you're getting a lot more stress. A lot of people come in with an SI joint pain. And that's where you kind of see what we talked about before, where a lot more stress is going on to those ligaments. And then if you have a vaginal delivery, the passage of the child is obviously increasing pressure onto that pelvic floor, which it shows into that picture. You can imagine, yeah, exactly. That is all pushing down on the pelvic floor when you're actually delivering the child. And then it can also lead to a little bit of some damage in structures, or some women get an episiotomy, which would be a surgical cut during delivery. But some people think that, pregnancy, it's only to do with the vaginal delivery. It's also really important cesarean section, because no matter what, you still carried that child for 9 months. So it doesn't matter what type of delivery you have. It's a huge change on your pelvic floor whenever you have a pregnancy. And then you can also get increased back pain. I'm sure many people kind of see it, especially with orthopedics. A lot of pregnant women will kind of walk in this APT, or so anterior pelvic tilt, and they'll kind of push their belly forward. And just because their center of gravity is changing, that is also something to kind of assess too. So if you're tilting your pelvis forward, obviously those muscles are also tilting with it. And so you can actually be stretching those muscles at the same time. Let's go to the next one there. Diastasis, this is something that is found in both men and women. So typically we think of pregnancy, which it is a little bit more common there, but it's when you can get a partial or a complete separation of the rectus abdominis muscle. So on the right side, that would be a complete separation, but you can have just around the belly button, 2 centimeters above and 2 centimeters below is kind of where we assess. So whenever I'm doing that, I'm kind of pushing straight into their, right into their stomach and seeing if there's any room for my fingers to go right down there. And usually if you can get 1 or 2 fingers in even like side by side, then that means there is typically a diastasis recti there. And so this is also common in postmenopausal men or women. You do not have to have a pregnancy in order to have this. So you want to avoid exercises that are obviously putting further strain onto your abdominals. So, push-ups, crunches, different things. And also depends on, you obviously want to work with a trainer. So that session next week with the trainer would be awesome for this, making sure you're going back to exercises correctly. But anything that's going to result in a doming or a pouching. So you're going to kind of see these muscles kind of pouch up. You want to make sure you're activating your transverse abdominis muscle, which is the one that's kind of going straight across in a horizontal fashion. And then focus on exercises like activating your transverse abdominis muscle, dead bugs, bridging exercises. And a big thing is that wearing an abdominal binder is not a long-term solution. So a lot of people think that if I wear this, this is something that's going to help and I don't need to, do anything else about it. But really important to work with, professionals around you that are familiar with it and can kind of give you the right exercises to go back to leading an active lifestyle. And let's go down to the prolapse. Okay, so these pictures are all different types of prolapses. So the very first one is the normal one. And then all the other ones are different types of prolapses you can have. So a prolapse just means that a pelvic organ is coming out of the vaginal opening. So it can be, you can kind of get this feeling of like heaviness or pressure sometimes in the vagina, which can actually be worse by doing certain types of activities as you're putting more stress into the area, or worse by standing, again, because of gravity. So the different types are named based on the actual organ that's coming out, but these would be erectocele, urethrocoele, cystocele, uterine prolapse, etc. If you just kind of zoom in a little bit to some of those photos, you can kind of just see that, yeah, exactly. So these are just different ones. I mean, the second one there would be your bladder prolapse, a cystocele, where that blue arrow is just kind of coming out. There's different grades, 1 to 4. 4 is if it's fully coming out of the vagina. A big thing that I say with this is that so many people will come in with a prolapse in varying grades. Not everyone is coming all the way out, but they feel discomfort. This is really a functional diagnosis. Most of the time, this is something that the organs are still going to work great. So this is not like you have to rush and get a surgery for it. The first line would be going through pelvic floor physiotherapy, seeing if we can really work on the pelvic floor muscles. And then there's different things that we can get, that we can insert, and kind of it holds up the organ like a little, almost like a sports bra. So there's different routes that we can go before going down the route of surgery. And then let's go down to the next one here. Perfect. Doing a good job on that.
Thank you.
And then urinary incontinence. So this one here, different kinds of incontinence. So you can get stress incontinence, which I think everyone's familiar with, loss of urine due to the increase of intra-abdominal pressure. So this would be you're going on a run and you're kind of getting a little bit of leaking. And then urge incontinence, so losing some of that urine after a strong, uncontrollable need to go to the bathroom. So there's different times where you might, as soon as you go home and you put your key in the door, it's kind of that cue where you start to lose control of your bladder. Or it could be that sometimes you get this urge to go and you just can't make it to the bathroom in time. So a couple of different reasons for those. Let's go down to the prostatitis. Perfect. So this one is in men. So there's different categories of prostatitis. The first two are typically one that pelvic floor physios will not see. These are usually ones that they will be going to their doctor and they'll be kind of treated with medication, antibiotics, and we will not see them. But when you get to the category 3 and 4, it becomes a little bit more of a crossover with chronic pelvic pain syndrome. And this is people that will be coming into the clinic. So you can get it with or without inflammation. Different symptoms would be, hesitating to go to the bathroom. Nocturia just means going to the bathroom a lot overnight. The frequency and urgency, you're not fully evacuating most of the time. And then getting any type of discomfort or pain in that area. Okay, and let's go down to the other 3 here. And so there are so many conditions and different things that I could go through. I could spend a lot of time talking about these, but the important thing is to note that there are so many different types of things that we see, and it's not really a one-size-fits-all. It's not just for women after pregnancy or stress incontinence. Here are 3 pelvic pain conditions. So dyspareunia is painful vaginal penetration in the absence of a medical condition or disease. So typically if people are having painful intercourse, but there's no known reason for it, this could be one. Vaginismus, so the inability to penetrate due to the muscle spasming. So this, again, it may not be just intercourse, it could be inserting a tampon, it could be anything like that, having a vaginal exam done. And then vulvodynia, so chronic vulvar pain, so it has to be lasting more than 3 months. That includes this, it's a really burning, stabbing, unrelenting pain that you can get there. And then so vestibulodynia and clitoridynia is just different areas in the body that can occur, so the clitoris versus the vulva. And then let's go down for evidence for pelvic floor muscle training. Good. So this is really interesting and super exciting. So with pelvic floor muscle training, for treatment itself, for stress and all other types of urinary incontinence, it's actually a level 1 grade A, which is the highest level that you can get. It's also the same with the conservative management of your pelvic organ prolapse, which is amazing. So there is one there for prevention, level 2 grade C, a little bit lower. But still, for the majority of people that you come in, this is a huge thing that we can treat in the clinic, hopefully before having to go to other medical means. And then let's go down to the hip and labral tears. Perfect. So I'm sure if we are working in the clinic, no matter what type of professional you are, you're probably seeing labral tears. And so these are just a few studies that have been done, which are really interesting. So the first one was a comprehensive review on the labral tears that includes labral tears that occurs more frequently in women, and that more than 90% of them actually complained of anterior hip or groin pain. So if people are coming in, and typically, especially when I first started with physio, I did not ask about groin pain when I was looking at labral tears, but really important to note, especially if it's not getting better in so much time, that there could be a connection to the pelvic floor there. And then Burnett and colleagues in 2006 studied 66 patients with a diagnosed labral tear, and 92% of them had a predominant localized groin pain, again, which may be something we don't necessarily pick up in our initial assessment. And then in 2012, there's a study done with 10 postpartum women who presented with a labral tear that began during pregnancy or delivery. So this is actually confirmed with an MRI, and they kind of assumed that this might have happened for a few different reasons. First of all, for delivery, vaginal delivery, typically there's excessive external rotation needed. You can also get hormonal changes, the relaxin hormone like we talked about before, and then you can also get that pelvic floor connection, the obturator internus muscle that connects right into the labrum. So obviously during pregnancy and delivery, that muscle is quite well used. Let's go into the low back pain. Perfect. So again, some few studies here. So Smith and colleagues found that women who reported urinary incontinence or GI issues or problems with the respiratory tract were more likely to have back pain, which is really interesting. I mean, how many people come into the clinic with back pain? It is very common. And I don't think before going into pelvic floor, I would have ever really have thought that much about assessing pelvic floor or kind of screening for it at the same time. So, and then there's also this study in 2013 that found using a self-report questionnaire that among over 1,600 patients with complaints of low back or pelvic girdle pain, 57% of them had pelvic floor concerns. And then Dufour in 2018 found that over 85 patients with self-reported lumbopelvic pain, 96% had pelvic floor dysfunction, and then 84% of them had an overactive or like a hypertonic pelvic floor, so too tight of a pelvic floor instead of it being weak. And then finally, in a group of over 200 women, Eliza and colleagues found that they had complaints of low back pain. 78% reported urinary incontinence. So again, not something I initially screened for when I had back pain, urinary incontinence, but it is really important to note, you know, how kind of important it is to kind of assess both of these things at the same time. And then breathing. So this is kind of a slide I threw in there. So during exercise, as your internal pressure increases, it quickly returns to normal, and it should be. So the pelvic floor is lifting, which you can kind of see in that picture right there. Your abdominals and your back muscles are kind of drawing in, almost like a little bit of a corset. And breathing, it should be pretty simple. But if there's a weakness or dysfunction, the pelvic floor can actually be overloaded, which is creating that downward pressure, which is the picture on the right side. And another thing that we kind of just take note is that when we're consistently bracing the core, so when we think of bracing the core, I think of doing exercise, which is totally fine, but a lot of us, I think, you know, the whole idea of sucking in your stomach and walking around with, you know, holding your tummy in can actually lead to your pelvic floor muscles being quite tight and stiff. So that's really interesting to note. I was definitely at fault for that as well. So I know there's a few people that were interested in like, how do I refer? Can I refer? Big thing is, how do you bring this up with clients? I mean, if they're not coming in for pelvic floor assessment, they're coming in for ortho, and especially if this is, you know, someone that you might be in an open environment when you're assessing them, you really kind of have to make sure you're asking the right things in an appropriate way. But just being comfortable with it is one of the biggest things. So a few things to kind of note: to make sure you ask permission to discuss the topic, especially if someone is not really expecting it. And then give them permission to discuss the topic. So listen, which is really important. Make sure you're comfortable, and then watch your body language. If you're really closed up, I mean, someone's not going to feel open enough to kind of really talk to you about these things. So make sure you really kind of pay attention to how you look as well. These are just some things that I've mentioned before, like you've mentioned you frequently make trips to the bathroom. Is it okay if I discuss it with you? Just a few little things that you can kind of take note. I notice that you seem to prefer positions where you aren't sitting down. Do you get any pain or discomfort in and around your glutes? Just different ways that you can kind of bring these up, little tidbits. The next slide is just should I refer? Yes, you should. So if you have a pelvic floor physio in the clinic, this is something that you can work, you know, with the other person. A lot of the clients that we see, if they have concerns with pelvic floor, I'm not taking the patient fully. A lot of the time, you know, I'll work on something perhaps internally while they'll work on something externally. And it has some really great outcomes when you can kind of get both of those working together. So it's really cool to see that too. And then I know a couple of people had also asked about assessment and treatment. So with assessment, so when we're going through this, I mean, generally, it's the same type of assessment that you're doing in any other type of, orthopedic assessment. We're adding in some things for sure. So we're going still through their history of presenting illness, but so what's bringing them in. But we're also going through a gynecological history. So we're going through like the menstrual cycle, if they've had any pregnancies, are they sexually active, do they have any discomfort with that? For men, we're looking at digital rectal exams in the past. Do they have any discomfort? Do they maintain satisfactory erections? Do they have any premature ejaculation? These are just a few things, but there are way more questions than this to kind of go through. If they've had any previous surgery, so I see a lot of people come in with hysterectomies, and that's kind of something that cues me into potentially some pelvic floor questions to ask. Bladder symptoms, so those ones that we've talked about before, kind of some things of dysfunction, so they may have urgency, leakage, pain, they might have some pain after dribbling or post-void dribble, which is pretty much after you go to the bathroom, you kind of have a little bit, you still feel like you have to pee just a tiny bit, you kind of get a little bit of the dribbles, or difficulty starting your stream, so you just have a difficult time starting to pee. These can be in men and in women. These are not solely for women. And then bowel symptoms, so frequency, urgency, you can get incontinence as well. You might be straining quite a bit or have some incomplete emptying where you feel like you need to go again as soon as you get up. The objective assessment is quite different. So this one here, you're still doing an orthopedic exam. I mean, it's no different than when someone's coming in. If they have a pelvic pain or any type of pelvic concerns, we're still doing a hip screen, we're still doing a low back screen. We're still looking at that entire lumbopelvic area, and then posture and all the same type of things. Sometimes we will look at a bladder diary. So this is something that we, for me personally, I may give them for after the first assessment. And it kind of just gets them to take note of what time of the day are they going pee, and then what time of the day are they potentially having a bowel movement. And they can kind of check off how frequently they're going, how much they're drinking during the day, different things like this that kind of takes note of. It might help me kind of understand their regular routines and things that we can kind of tweak along the way. And then we're looking at outcome measures. So same thing as orthopedic, there's a lot of outcome measures, definitely looking at some stress, anxiety, any depression. And then internal exam would be doing obviously an internal. So you can do looking at tone is really important, how much tension there is, how much strength they have, and then if there's any discomfort, among other things as well. And then you're looking at integrity of the skin and the tissues. But these are kind of the most important ones, I'd say. And then treatment. So I'll just kind of go into this really quick. If you are interested in pelvic floor, I mean, this is something that they will definitely go into largely in the courses, and I highly recommend. They are amazing courses to take. I did mine through Pelvic Health Solutions. So education is huge. Majority of people do not know what a pelvic floor is and do not even know that there are muscles inside there. Like I said, we all think it's this massive black hole with not much going on. So this one is really important. Behavior changes. This could be things like if you're going to the bathroom quite frequently in succession, if before you leave the house you have to pee 5 times just in case. These are different things that we can modify and kind of change. Same with the urge delay suggestion. So there's different things that if as soon as you put your key in the front door when you get home, it triggers you to kind of completely void and lose control of your bladder. These are things that we can give them little suggestions and exercises to do that will kind of overcome these. Review medications for sure, if we have to kind of talk with the patient's physician and their circle of care. Pelvic floor muscle training, so everyone's kind of heard of Kegels. A big note on Kegels. So Kegels are amazing, but they are not something that we should all just go and do Kegels. So a lot of people, when they have any type of pelvic floor concerns, they might start just doing Kegels. But if you have an overactive pelvic floor, you can actually exacerbate your symptoms. And so, half of us might feel better and half of us may not. And that's why it's really important to go and get an actual exam done to understand your best treatment approach for whatever you're presenting with. And then definitely liaising with the rest of the treatment team. So this is not a one-man treatment. I think it's really important no matter what type of treatment we're doing, whether it's for pelvic floor or orthopedic, that we are talking with other healthcare professionals and whoever's on their treatment team. I mean, if they are seeing a personal trainer, reach out and talk with the personal trainer and see if you can kind of both get on a good treatment regimen, or whoever they're kind of seeing, if they're seeing a massage therapist, whoever. And then I kind of just listed some lengthening exercises on the next one there. So the pigeon stretch, I mean, this one here, you're kind of doing like quite a nice, an opening, a lengthening exercise. Happy baby stretch. This is an awesome one, especially if you're able to get your feet. I don't know if I am, but that is one that I sometimes too just kind of modify it and get them to hold behind their knees and kind of bring their knees up towards the opposite, the shoulders. And then deep breathing, as we talked about before, I mean, your diaphragm is sitting right over top of your pelvic floor. And so you want to do some really great breathing exercises along with these pelvic floor relaxation exercises. These are really important. And then strengthening exercises, we have butterfly bridges. So it's your typical bridge. You're just kind of putting your heels together. And then your transverse abdominis activation. So this is one of those core muscles that we talked about earlier. But these ones are really important. Obviously, there's Kegels and such too, but like I said, I don't want to recommend Kegels for everyone. So these are kind of ones that I would start with unless we've kind of done an assessment already. So that is my whole presentation. Does anyone have questions at all? Anything they want me to re-go over? Sorry, sometimes I can talk a little bit quickly, but let me know.
No, that was great. I picked up quite a few things off that too. I mean, the back pain and the hip pain, like the labral issues.
Yeah.
Because I've seen that a few times too, and
Thank you, Sheb.
oh yes.
I recognize her.
And that's the cool part about like having an interdisciplinary approach, like having like a physio, for example, seeing somebody for the back and hip pain, and then another physio like yourself that specializes in this area too. So have that team approach.
Yeah.
Very interesting. I like that a lot because a lot of the shift to healthcare now is doing the interdisciplinary work and working as a team. And some like a lot of take home for physios is like the bladder diary. Anyone can get started, and you can have all these prerequisite things to do before you even refer to a pelvic floor specialist.
Yeah. Let's see, we have a question.
Which is great. So we got some questions now.
Yeah. So I'm like, mine's like opposite sides. I'm like, can you go over which muscle those stretches specifically target? Yeah, so the muscles that they specifically target, so if you're looking at the lengthening exercises, I mean, do you have it there? I can flip this.
I can pull it up quickly.
Here, I can just also flip. Here, let's do this. Does that work? Yeah. So the pigeon stretch here, I mean, these are all exercises that, so a lot of those muscles that we talked about earlier. So, let's go back a little bit here. I'm just going to kind of bring you back. We have the outer layer of muscles. So we have the bulbospongiosum or cavernosus, whatever you want to call it, superficial transverse. So these are all ones, the outside layer. We're not necessarily stretching those ones as much, but that deep inner layer, so that third layer that we are getting into, so levator ani, these are ones that you're going to, anything that's a longer muscle, you're going to stretch with these ones here. So you're going to kind of, if it's crossing over into the hips, so obturator internus, you're looking at stretching that with these happy baby, with the pigeon stretch. But when we're looking at kind of stretching those small little muscles and really kind of getting the pelvic floor as a whole, that's when your breath is so important. And I think that a lot of times, even myself with exercising, we really forget about how important breathing is. But when we're breathing, I mean, when we get people to do relaxation exercises, as you inhale, naturally your muscles are actually kind of relaxing and lengthening at the same time. So diaphragm's coming up and pelvic floor is dropping down. And this is a really great time to kind of just let everything relax and let go. And that's when you kind of start to stretch those muscles out. So it's not like it's targeting one specific muscle at a time. It's not like when you're doing clamshell and it's hitting glute med. You're kind of getting a bucket of these muscles at a similar time, but you kind of need to take the two approaches in order to get the shorter muscles and to get the longer ones that cross over into the hip. I hope that helps.
No, it's great. That's good. We're probably going to get some more questions, I assume. So I'm glad we have some time to work on that.
Yeah, I never leave enough time for those, and then it's always like 5 minutes left. I'm like, whoops.
We've got like a solid 50 left. I was going to ask, like, I know, like, for me, what I hear about always is like pelvic floor weakness. And then you commented on overactivity, and that was quite interesting. Like, is there like a breakdown that you have of like how many patients that you see that have overactivity and how many have like a weak pelvic floor or inactive?
Yeah, I mean, I would say it's almost 50-50. typically we kind of think of like people coming in that have had pregnancies in the past, and they're having a little bit more of a weaker pelvic floor. But
Yeah.
that is not always the case. I've had people come in and they've had 4 babies before, and they're coming in, they're actually presenting with too tight of a pelvic floor. And one way that I kind of think about it is because people tend to think about tight pelvic floor. I mean, just like we hold tension, you know how your traps and everything get really tight up here, and you just feel it all day when your shoulders are up here. It's the same thing with our pelvic floor. So the pelvic floor is holding that tension. And one thing to note is that I always kind of give an idea of is that if we have our bicep muscle and we're doing a bicep curl, naturally we want the muscle to be nice and lengthened. So if we're starting here and we're kind of bringing it up, great activity. But if your muscle is already tense and it's starting up in this closed position, we're not getting as great of a bicep curl. And that's the same thing. So if your muscles are really tense, we're not going to be able to activate them as well. And so they're not going to be able to perform those 5 functions that we talked about earlier.
Yeah.
And this is when you're getting different dysfunctions. You're getting perhaps some urgency, because if this muscle is so tense, it's not controlling helping the bladder as well as it should be. Whereas on the other side, typically when I get men, a little bit more, I would say a little bit more on the tighter side than decreased strength, but it really depends on the situation. So yeah, I'd say close to 50-50. But that's why it's so important to get an exam instead of just kind of assuming that you have decreased strength and going to town on your Kegels and then realizing that you maybe did it a little bit worse. The question there.
Yeah, like that's one thing that's just always commented is weakness, weakness, weakness. I think it's quite a few areas, and yeah.
We're back. Mentioning Kegels. Sorry for my slide here. That's the greatest for everyone. So I think that question is saying if you have low back pain and you're teaching people a core exercise, yeah, so I think it also depends on how much you give them in terms of prescription. So if you're telling people to do 25 to 55 Kegels a day, that's too many. If they're doing 5 of these exercises and you're getting them to activate and, activate your pelvic floor, I don't kind of like seeing as much is when people just give people Kegels and they don't really understand why they're giving the Kegels. Oh, you got it there.
It froze.
Good. Oh, interesting. Okay. It's because it's probably snowing here. It's okay.
Oh, God.
Yeah, it's gross. So if you have that low back pain, understanding how to actually activate these muscles is one thing. I think that's really important. And a lot of us don't know how to activate our pelvic floor. Even when people do a Kegel, making sure they do them correctly. Sometimes you'll see them overacting the whole glute and the inner thighs and everything else. But in reality, if it's a female, I get them to say, some people use a blueberry, make sure there's a blueberry at the opening and trying to pull it in. Or if there's a tampon in the opening, pulling that in. Or if there's a tissue that's open, you're kind of pulling all 4 corners up and in. Whereas if it's a men, you can kind of tell them to shorten the penis, which is activating the front part of the pelvic floor. So a lot of these, making sure that they have the right cues, I think that's completely fine to give them that exercise. But if you're getting them to do 30 to 40 of these, maybe leave out the Kegel aspect after the first 5 once they know how to properly activate it. But that's when I would definitely link up with just a pelvic floor physio. It's not that they have to go and get all these sessions, but maybe just kind of getting an assessment and seeing where they're at, and then they can kind of work together on getting the best exercise program for them. I hope that answered the question for them. If not, let me know. I can re-explain it.
That definitely answered it for me. That makes sense. Thanks. Okay, good. Very good. And then what about recommendations? And I know it always it's a depend kind of scenario. In terms of after giving birth, what's an easy to follow protocol for getting back into the gym? Because I know we have a lot of people that do a lot of resistance training that might be on. And I guess it does depend on if it's a natural birth or a C-section or something like that. But what's a good rule of thumb that people could follow maybe?
Yeah, so usually, obviously given they have to clear it with their doctor, obviously, to return to exercise. But if you're talking about they've done all the progressions and they're ready to go and do deadlifts and all this, I would say so long as they don't have any pelvic concerns, it's not that every single person has to go and be referred for pelvic floor physio. but it does help. And if they've had a baby recently, doesn't matter if it's their first or their fifth, I would still recommend just going and getting an assessment done because, I mean, especially with deadlifting and if you're doing really heavy kind of strength exercises, a lot of people even kind of timing breath properly. Now, any physio, anyone can do that. But making sure if they've had any tearing, so it depends if you're comfortable kind of getting into those questions. If they've had any tearing, if they've had any forceps or the vacuum assisted deliveries, those are all really important because it just can lead to a little bit more kind of damage and stress in your pelvic floor. So that's when I would kind of get them to potentially refer over to the pelvic floor physio, get a session, and they might be totally cleared for it. But I would say the biggest thing is, do they have any concerns at the time, right? Do they have any stress incontinence? Or some people too also just need to hear that their tissues look good and they're safe to go back, because when you've had so much, you have this delivery and you've pushed out this 8-pound, 6-pound child, a lot of people are also just a little bit concerned. They don't think that they can go back to some of these activities. But just reassuring people and giving them that education that your body is, doing well and that everything looks great is a huge thing, especially maybe if it's your first pregnancy too.
Yeah, I could assume it's quite stressful and like a lot of questions that they have. And then like tying into that, I guess I may as well ask another question.
Yeah, of course.
Right now is like, I like a lot of prehab and prevention. Like for me specifically, more so like shoulder, hip and knee and back kind of stuff. Do you find a lot of people are coming to you for prehab or prevention, and like how big of an impact does that make? I assume it's huge, but
I definitely have a lot of pregnant women that come in for, I guess you could say, prehab. And so usually it depends too, like, again, what type of birth are they looking for? Some people will come in and they know they're getting cesarean section, whereas some people are coming in and knowing they're going for a vaginal delivery. And so then at the very start, depending how early they come in, so if they're coming in quite early, making sure the body is kind of nice and strong, working on activating your transverse abdominis, working on co-contracting your pelvic floor with your transverse abdominis is really important, which is what somebody had asked earlier. And then working on the breathing exercises. And then as they kind of progress throughout the pregnancy, depending on what we find in the pelvic floor, if they need some relaxation exercises, if they need some strengthening exercises, we do those. And then once it kind of gets to that 35-week, like up to the getting ready to deliver, we can kind of get into some like perineal stretching exercises, and different things that they can do, different things that I can assist with or their partner can assist with in preparing for delivery. And then just kind of getting them, it's more making them comfortable so that when they come back afterwards, they kind of know what exercises to do. And, they're just a lot more comfortable with their body. If you're getting into like labor and delivery, I mean, there's tons that you can do in terms of like birthing positions. You can kind of get all into that type of work. But if we're looking from strictly like the muscle-based exercises, it pays off quite a bit. And typically they have a good outcome. It's not the, like in terms of the evidence for, this is more of like the prevention type of thing. It's not level 1 grade A. However, I think it's really a case-by-case basis. A lot of people find that there's still a ton that we can do for people, and just kind of getting them in that right mindset. Because for some people, when they come in, they're nervous, especially for these deliveries. And so just kind of easing them, a lot of education is really helpful.
Okay, that's great. Thank you.
See, I don't know if there's any more.
Another question.
I'm just not sure if this is a way to determine if someone is overactive. They're doing an internal exam, especially for males. So unfortunately not. So the question is there a way to determine if someone has an overactive pelvic floor without doing an internal exam? And no, unfortunately, we cannot find that. You do have to do an internal. Sometimes when people have come in, there's been a time where I'm like, I'm quite sure this is going to be a weak pelvic floor. You kind of just assume at the very start, and then you go in and it's actually an overactive pelvic floor. Now, I mean, typically when you kind of get some types of incontinence, you're leaning more towards one type than the other. However, super important, this is the benefit of doing an internal exam, is that we can fully assess those muscles. And it's pretty cool. I mean, it's just like here, right? We actually get to feel the muscles. And so I wouldn't be able to know if someone's muscle in their, their chest or their arm or their back is too tight without kind of working in and actually assessing the muscle directly. And I think there was questions to ask in history taken that might point you to overactivity rather than weakness. I mean, yes, 50-50. Again, some people will come in with like a urgent continence, and typically when people have an urgency frequency, like they're going to the bathroom all the time, or they can't make it to the bathroom in time, so potentially they're voiding as soon as they get home, and they're just kind of completely voiding their bladder. This is something that usually there's a little bit more of an overactive pelvic floor, whereas if you're doing like a jumping jacks and you're getting weakness, this is more of a decreased strength. Also is that pelvic pain condition. So if people are having like different types of like pain with intercourse or during vaginal exams or different things like this is usually more of a tension-based issue. So these are different reasons that you'd kind of want to send someone over to kind of get a check. Is there any stretches or things I can do to pinch plate? Oh, does it continue on? Oh, use the formula. There we go. So is there any stretches or things I can do to help stretch out the L5, sciatic, and hip? I have a pinched plate and it's unbearable to move or walk, and I've tried multiple stretches and have used a foam roller. I mean, with this is a kind of a mix of the pelvic floor and the orthopedic. So some of the exercises, you know, for if you're just going for purely back, these are ways that I would kind of work into your cat-cow. It says pinch plate. I'm assuming they've probably had an assessment. First of all, I would say go get an assessment by a medical professional that you completely trust, a physiotherapist or someone else. But based on what you're kind of saying, if you're doing this is when I would kind of get into relaxing the pelvic floor. So that pigeon stretch or the happy baby stretch would all be ones. And I'd really focus on some deep breathing and core activation. So this is finding your transverse abdominis, which I mean, technically you can look up. But I would highly recommend, a lot of the physios are also doing telehealth right now. Reach out to someone and get them to get a specialized treatment program that's just for you. It's not a one size fits all, unfortunately, and I really want you to get the best treatment. Good there. I just see if there's anything else.
No, I think it's all up to date. Before, like, it will cut out, I guess, in like a few
minutes. Yeah.
I wanted to thank you again for joining us. That was a lot of fun. Like, these things like make me kind of really excited to continue on and learn more myself. So like, thank you to you for teaching me.
Yeah, thank you for having me. It's awesome. And I think that, you know, I was saying before, I love pelvic floor, and I think it's such an important aspect for everyone. But I mean, orthopedic is just as important. It's just that it's really great when we can all work together, and It's fantastic for the patient, right?
Yeah.
So just provide some great outcomes.
Yeah, that's the thing. Like, it's always about patients number one, and then if we just kind of tailor things around it, then we're always doing the best we can. And then having that team aspect to kind of lean on each other is great. And it's kind of like what I'm looking for as my dream of being a clinic owner and things like that. So, and then next week or the week after, I'm going to try to link up with my colleague and then look at like some training and more exercises and stuff like that, like after giving birth and things like that, which I think a lot of people would like. And then it'd be good to have you on it too, so we can maybe do a trio or something like that. You're on the spot now, so you kind of have to say
No, that's fine. I mean, you can you can let me know if you want me to just jump in at the end, or if you just want me to be there in case whatever. But yeah, I'd love to watch it myself. And I think that might be Brooke. Thank you. I appreciate you signing in for that.
Yeah, and it'd be good because any other day that you're on, or if you do have free time and you want to always like give some more information, just let us know, and then we can get you in live, because we're going to be doing this every day, so there's going to be a lot of topics.
Yeah. No, that's awesome. I think it's fantastic. I wish when I was in school this would have been like a perfect thing. But it's great for everyone, right? Like, especially like not everyone, I'm assuming, here are physio, so it's fantastic. Good timing for this too. So thank you so much for having me.
Yeah, no worries. And like you said, for students right now, I think this is being shared with U of A, the physio program. They're studying now anyways, but it could be a good break for them, or to get some more. This, for instance, isn't covered in school very much for us. Like the TMD stuff that I did wasn't covered in school very much, just because, I mean, the programs.
There's just so much time.
Yeah, exactly. And then like with Brandon and chronic pain, pain science, and pain management. So it's cool.
It's huge, important. Yeah.
It's massive cool to get all these like specialty topics done, because then it gives everyone, from patient perspective, from our perspective, and from like physio